Hi, Dr. Brian Kaufman. I'm the Executive Vice President, Chief Medical Officer of the CLL Society here at ASH 2023 in sunny San Diego.
And I'm Amber Kaler. I'm a PA at Mayo Clinic in Rochester, Minnesota, specializing in CLL.
So, Amber, we've heard a ton of exciting information about how the new therapies are changing how CLL is treated, how people are living longer, the efficacy is better. While there's not, side effects haven't disappeared, we're having fewer and less serious side effects. But to their credit, for really, the first time I'm hearing, there's more attention on quality of life. And working at Mayo, you have some databases that you can go through. So can you tell us a little about the research that you got to do, an oral presentation, which is really quite an honor to get to do an oral presentation on quality of life. So you must have done something important. So tell us what you did.
Yeah. I think it's beautiful, right, that we're in this space in CLL that for so long there's been so much emphasis on efficacy and getting better treatments. And now we have really great effective treatments, and certainly we have a ways to go, but this ability to move into that space of quality of life is really wonderful. So what we did was we used a database that we have where patients are enrolled at diagnosis, and we prospectively collected patient-reported outcome data.
PROs.
PROs, yes.
Patients are going to hear a lot more about PROs going forward.
Good, as they should. And we use something that's called the FACT-G subscale, or Functional Assessment of Cancer Therapy General. So this consists of 4 subscales. So the themes of those scales are emotional well-being, functional well-being, physical well-being, and social and family well-being. And what we looked at were what were those baseline scores in patients with CLL at diagnosis who were initially managed with observation or watch and wait, and then how might those change over time?
Very cool. So I'm very interested, but before we get to that, let's talk about that language there, because the language that's used in CLL is watch and wait, but in other cancers where there's treatment isn't imminent, let's say prostate cancer, and if it's a low-grade prostate cancer for men, it's not called watch and wait, it's called active surveillance or sometimes active observation. Do you have a feeling about that language? Because all the language is watch and wait, but at the CLL Society, we think that something like active surveillance implies what really happens, that we're really watching it, that we're actively involved, we're seeing how it goes so we can be ready to know if and when it needs treatment. How do you feel as somebody who just studied this and looked at patients' sense of it?
I think that's beautiful. I think, when you think about distress, and there was a Mayo Clinic Proceedings article a few years back that talked about controllable versus uncontrollable stress,
right,
and how uncontrollable stress can be so much more impactful in kind of creating distress, shutting down our decision making in the prefrontal cortex. We live more in our emotional brain. But I think what you're saying, active surveillance, really gives more of that onus or locus of control back to the patient. And I would love to see the language shift in the field.
And I talk about this a lot, about that locus of control. And CLL may be a big actor in the play of your life, but you're still the director and the producer. And you get to decide, not all the time, but what they get to say and what they do on stage. So I'm very interested in what you found. So tell us what you found, but at baseline and how that evolved, and very interesting. And I also understand you studied 2 time periods too. So
we did, and so a couple of things I'll say. So one is, for the majority of the analysis we presented yesterday, we combined those 2 cohorts into a single cohort. So this was data from 2002 until May of 2020. So I think that's a key piece of that, right? Because we all know that the COVID pandemic has created immense amounts of distress within the population of individuals living with CLL. And so I don't think a lot of that is captured here based on that timeline.
And also, if we're looking at 2002, we're looking, we celebrate 10 years of the first targeted therapy, ibrutinib, but that's taking us back to 2014,
Exactly.
So a lot of this was when the only options were chemoimmunotherapy.
Exactly, yep. So I think there were probably a few key pieces. So one is we looked at baseline quality of life in patients with CLL who were managed with active surveillance as their initial management strategy. And we actually prospectively collected data on 610 patients.
Guys at Mayo are ridiculous.
So it's amazing. Yeah, it's such a wonderful team, and we're very thankful to the patients for being a part of this, because we couldn't do that, obviously, without them. And what we found was that when you looked at each of those subscales, so physical well-being, functional well-being, social and family well-being, and the total score on that FACT-G scale, patients with CLL actually had improved quality of life compared to published population norms.
Wow.
The difference, though, was that they had significantly decreased emotional quality of life at baseline compared to the general population.
Any thoughts about that?
You know, I don't think that's new. I think it probably relates, we've seen it in prior data from, Tate Shanafelt's survey. We've seen it in work from your group, that certainly emotional quality of life is a big problem in CLL, and I think there's a lot of reasons for that. The good news that we found in our data was that even though it is low at diagnosis, we do see ongoing improvements in emotional quality of life over time during that active surveillance period.
Yeah, patients talk a lot about this phrase, cognitive dissonance, that, like, I've got cancer, it's incurable, and you're not going to do anything for me.
Yes.
Were you granular enough to kind of look at what that anxiety and depression was like, and can you fill us in on some of that?
Absolutely. So if we look specifically at a few of those emotional well-being line items on the subscales from the FACT-G, there were a few of them that we focused in on quite a bit. Worry about the disease getting worse. About 75% of people are still 5-6 years into active surveillance, or watch and wait if you're using the current terminology. 5 or 6 years into it, 75% of people are still worried about their condition getting worse. I don't think that's surprising. This is an indolent cancer. This is something that is likely to progress at some point. The second thing that we found was that about 50% of people, again, 5 or 6 years into this, expressed worry about dying. So those were two key components. There were also line items that were specific to acceptance or feeling nervous. You saw the highest amounts of feeling nervous at diagnosis. There was some improvement in that over time, but still about half of people reporting feeling nervous to some degree. And then coping was another line item, and it's kind of a double-edged sword. I think the good news with the coping line item is we did see ongoing improvements over time in people describing feeling satisfied with how they're coping. However, there was a small proportion of people, but not insignificant, that didn't really change in terms of that chunk over time. And what that tells me is that there's still a proportion of people who are not at all satisfied with how they're coping with their diagnosis 5 or 6 years after the fact. And I would love to see us do better.
Very interesting. So I have a million questions on that. But first is, when we've surveyed our patients, which is a different way of looking at the same group,
Yep.
We found that anxiety was the overall emotional problem for people, much more than depression. Were you able to look at that and tease that out too?
It's a great question. So the FACT-G subscale doesn't really break it down into anxiety versus depressive symptoms, but to your point, I think the feeling nervous line item probably would be most representative of the anxiety piece.
Did you have any sense about the patients who seemed to have developed better coping skills, or is there something different about them? Did they have a significant other? Were you able to, were male versus female, age, were prognostic markers, did 17p be more nervous than somebody without a 17p? Were you able to get that detailed?
Yes, so you're asking a lot of really good questions. Some of those analyses are ongoing. I can speak to, we did look at it by CLIPI score, so the CLL IPI, or International Prognostic Index. So that's a tool that we use at Mayo often. Other places sometimes do or don't use it, but essentially it's a couple of different factors based on age, rise stage of their CLL, what are their different FISH factors or their IGHV mutation status, and we use those to create a composite score on a scale of 0 to 10.
Right.
And that kind of plops people into one of 4 categories, so low, intermediate, high, or very high risk. And so for our study, we combined the high and very high risk into a single subgroup of high risk CLIPI score in order, to keep numbers, high enough to have
to
meaningful
get any
analyses.
statistical analysis.
Exactly.
Yeah.
And what we found was that if you looked at the FACT-G total score, so the composite score of each of those 4 subscales I mentioned, there's some up and down, but general stability and crossing over of those 3 lines, low, intermediate, and high risk CLIPI scores, through about year 3. But at year 5 or 6, that's when you start to see a significant decline in quality of life in patients with the highest risk CLIPI scores. Now, those were relatively small numbers of patients, but that pattern persisted across each of those 4 subscales. It was most notably decreased in the subscales, both on social and family well-being and the functional well-being.
That's so interesting. And there is, I wonder a little bit about that as patients become more knowledgeable and say, hey, I'm kind of beating the odds here. I'm a little bit of an outlier here. And I know for myself, there's a lot of patients talk about scanxiety, I'm
Yes.
going for the imaging, or
Yes.
I'm going to have my blood test and my counts taken off since the last time they were done.
Yeah.
A lot of people who are doing well don't think about their CLL until they go
Correct.
the day of their doctor's
Yes.
visit, and then
Yes.
they're waiting to the patient portal,
Yes.
plops down what their white count is. Yeah.
Exactly. I hear that from so many people. And so one thing that a few patients have shared with me that they do is they intentionally schedule sessions with their counselor or their therapist around that time they know they're going to have to make the appointment, and then kind of in the before and after period surrounding the appointment. So a couple of people who, have those experiences have found that to be helpful.
I'm so excited you and your colleagues are doing this work at Mayo, and I'm really eager to hear more as you look at it, because
Yeah.
you just crack open the door and you want to ask
Yeah.
a million more questions.
Yes.
Any final thoughts or anything you think the patient community should know about this research?
Yes, one other thing that we haven't touched on that I think is really important, particularly related to the work that CLL Society is doing. And what we found is that in all comers with CLL managed with active surveillance or watch and wait, what you see is an ongoing statistically significant decrease in social and family well-being the
Wow.
further out they get from diagnosis. And when you look at those line items, what you see is that patients are actually reporting ongoing decreases in support from both their family and friends the further out they get from diagnosis. And so I see that as a huge opportunity to increase that support, increase engagement in support groups. How do we activate and support and encourage caregivers and loved ones who come around our patients in their daily lives? But I'm curious if you have any other thoughts or suggestions.
No, I think you're absolutely correct. When you get the diagnosis, everybody rallies around you, and there's all this kind of, what can we do to help? But especially with CLL patients, which is kind of a closet disease, you don't look bad, you don't lose your hair, you don't lose weight, generally you do pretty well until you don't. Mm-hmm. And so I think people sometimes just get tired of, what's going on? Does this person really have cancer? What's
Right.
going on here?
Right.
So I think people lose that support and interest in the pampering that they might get at the beginning. And I think that's why having a support group and other people who've been through that and know what that's like in that transition and that shift, I think is really important for people. And we spent a lot of time talking about that kind of emotional roller coaster for people.
Yes.
To support them so that they can be best prepared for when they do have to make decisions. It's tricky, isn't it? Because we know that for some patients, they're never ever going to need therapy. And it's not an insignificant number, up to maybe 1 in 4, 1 in 5 patients never need therapy. And everybody hopes that they're going to be that one,
Right.
So it's a very tricky time. So I'm very understanding of patients. And I think when they get to talk to someone, also when they get to see someone who's maybe had the disease for 20 years, and they say, oh, they look pretty good. They look okay. I guess I'm not going to die of this tomorrow. It's what a support group can do is so helpful.
Yep.
Well, I'll give you one more chance to say any final thoughts or anything.
No, I think those are the key pieces. And, I think it's great that we have this data as a launching pad, because now the next step is, to your point, what do we do to help patients, and how can we do better to support people outside of these great treatments that we have and more coming down the pipeline.
Cool. Thank you so much for everything you're doing. Thank you.
Yeah, thank you.